Fellowship of the Great Physician welcomes you to House Call. Our hosts today are doctors of chiropractic, Dr. Gerald Lala and Dr. Richard Jensen, who is also a board-certified acupuncturist, practice independently in North Oaks, Minnesota. Let's join our hosts for today's program that will assist you in your quest for optimum health and well-being.
Welcome to House Call. I'm Dr. Gerald Lala.
And I'm Dr. Richard Jensen.
Wonderful to have you with us today. It's a bright and beautiful day. Maybe where you is, it's raining and cloudy, or maybe it's nighttime, but where we are, it's a bright and beautiful day, and we're happy to have you with us. As the screen says, we're starting a series called Eliminating Diabetes and Related Illnesses Naturally. So we're going to talk not just about diabetes, but hypertension, high blood pressure, hypercholesterolemia, a lot of different diseases, and I think you'll like this series that we're beginning here. So, in fact, diabetes, hypertension, hypercholesterolemia, Parkinson's, muscular dystrophies, muscular sclerosis, arthritis, they all can be prevented. They really can. And we're going to begin by discussing what a person wrote us a letter here, and we welcome your letters and your emails, what subjects you'd like us to address in the program. They said, Dear Doctors Lala and Jensen, what is insulin resistance? Well, insulin resistance is a major health problem today, and I'm going to give the podium to my esteemed colleague, whom I believe in, Dr. Richard William Jensen, who's going to begin a discussion about diabetes and the relationship of insulin resistance. Thank you, Doctor.
Thank you, Doctor. Insulin resistance is a major undiagnosed health problem today, and what we can find now is some of the research and some of the statistics that are kept on it show us this fact as we look at this first graph. This is estimated total prevalence of diabetes in people aged 20 years or older by age group in the United States, and this was a study done in 2005. The first group that you see on the left-hand side is the decades of the 20 years to 39 years of age. Then in the middle, it's 40 years to 59, and then those that are over 60 years of age. And what we're seeing a huge increase in that, is that you've got about 3% between ages 20 and 39. You have about 10% of the people in the 40 to 59-year-old, or 20% of those have diabetes. And over 60 years of age, we have 20% of those people have diabetes, both diagnosed and undiagnosed. And so as we go to the next here, we're finding that in this source group here, we have estimated age-adjusted total prevalence of diabetes in people ages 20 or older by race and ethnicity in the United States. This was a study done in 2005. Also showed that of the cultures, if we look at the bottom, there's the non-Hispanic and whites. They had 8% of that population had diabetes. Hispanic and Latino Americans, it rose to about 14%. Non-Hispanic blacks were slightly over between 14 and 15%. And American Indians and Alaska Natives had the most insulin resistance or diabetes at 18% of the population there. So, who are at risk? Well, we find that the number of persons with diagnosed diabetes has been climbing since 1958, and has been climbing this is finally, the end of this is in 2003. You can see where it rose from 1 million, just slightly over 1 million, to over 13 million people in, say, 3, 4, 5 decades of people, and approximately 90% of Americans have insulin resistance. 18.2 million Americans have diabetes, and over 5 million are undiagnosed diabetics, and 13 million are diagnosed diabetics. And the average time from onset to diagnosis is usually 4 to 7 years due to the insidious nature in the early stages. And actually, that's actually a little bit different there because there are stages that are leading up to diabetes that last for about 15 to 20 years.
And interestingly, because now with cost controls, and that's a good idea in healthcare or anything else, they're doing less diagnostic testing,
Right.
spending less time with the patient. So they're in the pre-stages of diabetes, which are not symptomatic yet,
Right.
and they're not doing a blood test, a blood scan to see where that person's health is when they're still feeling good.
Right.
So we wait until the person starts manifesting symptoms
Right.
rather than say, let's do a blood scan twice a year. Let's do it. It's not that expensive. Let's do it. Let's monitor it. I mean, it's a pretty good idea to check the dipstick on your oil at least twice a year in your car.
It's like looking at hypertension and you have a blood pressure cuff but never used it. That's what it's like.
Or going into the doctor's office, the nurse checks the blood pressure before the doctor comes in. That's fine. They say, well, it's a little high or it's a little low. Well, it's not high enough to be real concerned about, and it's not low enough to be real concerned about. When in fact, those are like a yellow light at an intersection saying, hey, there's a warning light going on here. So they say, well, lose some weight. That's a good way to always deal with people. Cut back on your salt. Oh, that's a good way to cut back on fat. Get more exercise. Okay, fine, that's good. But it still isn't going to change that blood pressure often dramatically because they are not looking at the internal biochemical causes of it.
Right.
They're treating the outside.
Right. So then we want to look at what is insulin resistance. And Dr. Lala, do you want to go through what insulin resistance is?
Yes. What is insulin resistance? Resistance, this is a chief symptom of adult onset diabetes, which affects about 15 million Americans yearly, as many as 1 in 3, caused by repeated overconsumption of refined sugars, which leads to insensitivity of the body's cells to insulin. So in other words, our pancreas, right up in here, produces enzymes. One of them is insulin. The other is pancreatic lipase, protease, and amylase. So that's for sugar or starches. Well, the more that I put in refined sugars into my body, the harder that pancreas has to work at trying to minimize, to metabolize, and bring those sugars back down to a normal level. Because when I eat refined sugars, my blood sugar goes up, my brain and my body says, ooh, that's nice. But now that's diabetic, bing, 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 bing. So the insulin goes, pancreas secretes the insulin, insulin brings down, metabolizes down that sugar, and so then our sugar goes down, and we need more energy, so we get more sugar, and we have this vicious cycle. It goes around and around and around, and pretty soon the little old pancreas goes, praise the Lord, I'm starting to wear out, baby. Do something about it. Oh, and then somebody comes along and says, well, those two chiropractors, those Christian chiropractors on television, they're always talking about this stuff. Oh, what do they know about it? My medical doctor says, don't worry about it. Or my nutritionist, or my chiropractor, or the person at some drugstore or health food store says, well, take some chromium, that'll take care of it. Well, it might, but there's no scientific basis to it. So, now, again, I want to read that to you once more. What is insulin resistance? This is the chief symptom of adult onset diabetes. It is a symptom which affects about 15 million Americans, as many as 1 in 3. So there's 2 of us here. This third person here is probably the one, because it's not going to be he or me, because we know how to take care of it. We're not going to eat those refined sugars over and over again, at least when our wives are in our presence. So we have to be careful about taking in those refined sugars, because when we do, it leads to a hyperactivity or an insensitivity of those islets of Langerhans in our pancreas that produce insulin. Now, what are the initial problems of insulin resistance? The initial ones, okay? Dietary predispositions to refined carbohydrates, saturated fat, found in beef if it's saturated. I mean, you can go out and get a lot of fast food restaurants where the fat is saturated. How about lean beef? You're not going to pick up the saturated fat in lean beef. There's a lot of good animal people who raise cattle who are producing cattle that are not full of toxins and pesticides and hormones, and all appear to increase the risk of insulin resistance. Yes, Doctor?
Now, if we look at this list here, the reason why these dietary predispositions are involved is, of course, refined carbohydrates and having to deal with them with use of the insulin. But then the saturated fats change change actually the shape of the receptors of the insulin and make it so it's like a lock and a key. If the lock is deformed, the key's not going to have a much harder time unlocking it. And then, of course, we look at omega-6 fatty acids, and they actually have been shown to increase inflammation, which shuts off the signal inside the cells. So this is where we have a predisposition. These are just not willy-nilly dietary things that we're looking at. It's a predisposition towards the sensitivity of our peripheral tissues to insulin.
So true. So what are some of the predisposing factors then to diabetes or adult onset diabetes or insulin resistance? One is certainly genetic. The other is environmental. Now, 90 million Americans have genetically related insulin resistance, most of which is the result of genetic mutations due to forefathers eating diets high in refined carbohydrates. Environmentally related diabetes is related to the person themselves eating excess amounts of refined carbohydrates. Now, if you would contact us on one of our other programs, Dr. Jensen talked about epigenetic, wasn't it?
Yep, and
Why don't you discuss
it will be
that?
later in one of these sessions also.
That. So
we'll hold off for that for right now.
So I have these genes. I'm 6'4", I have blue eyes, and I am handsome, and I look 30 years old. Now, if I want to look 20 years old, I can influence that, not just by surgery and exercise, but I can influence that by the way I eat. I will still have brown eyes. I will still be 5'8". I will still be that way, but I can make a positive influence on those genetic predispositions, and certainly, most certainly, I can make a positive influence by changing what I am doing in my own environment, right?
Absolutely.
All right, so what's the big risk here then?
Okay, the big risk for insulin sensitivity is, of course, the sugar that remains in the system and the glycosylation that occurs. Sugar is sticky. And so glycosylation is where sugar binds to proteins, and the cross-links between those, and the end result is being much like your body's proteins, including your DNA, being tied in knots. When things are tied in knots, they just can't function as well.
So the prefix glyco means glucose.
Right.
And silination means breaking it down.
Right. Or, well, actually, glycosylation means the addition of sugar
to it.
in here. So what's happening is the sugar is globbing onto the proteins, creating cross-links between them, and they get tied in knots.
And then it affects our DNA.
That affects our DNA. And in another way, what it does is it ages things, much like red blood cells, much faster is what we're going to look at this next.
Then if I continue to eat more and more refined sugars, the likelihood, would it be possible that the likelihood that I would end up with Alzheimer's is pretty good?
Yes.
Because I'm affecting the DNA in my brain and nervous system.
In fact, one of the things for Alzheimer's is that they find is a high aluminum content. And what they find is people who are sensitive to insulin or insensitive to insulin, they find in them that they actually have higher rates of aluminum within their body.
All right, how do we determine if they have this aluminium in their body?
Well, that's where it comes down to the testing.
But
The
what
testing,
test?
you just
But
can't.
that must cost thousands and thousands of dollars.
Well, there are some tests that are less that we can use as more of a scan to see what's going on.
So there are
And
less.
tell us whether we have to go through the more advanced
Right,
testing.
so there are some initial inexpensive tests then,
Right.
such as.
Well, if you look at like the hair mineral analysis test, that looks at
So
the
it's like a
excretion.
biopsy?
It's a biopsy of hair. And it looks at the excretion of metals over the past 6 weeks. So it's very sensitive in that it accumulates in there, and so that we can see if there's predispositions to it. Now, there's some chemicals that what the body does is it walls it off in the brain, in nervous tissue,
so it becomes
and
deposited.
in bone. So in which case, we don't see that in that, but the lack of it shows us that we need to do some further testing as well.
So that's all a person has to do then is have a hair mineral biopsy and they have all the answers?
That would be an initial test.
One test.
One test, and that usually tells us the other tests that should be performed from there.
So then we would order a blood test then to see.
We would order two kinds of blood tests. One that would be a whole blood cells and a packed
But
red
just
blood
a minute,
cell.
that might interfere with me buying a speedboat.
It might, but if you can't live to enjoy the speedboat, why buy the speedboat?
Well, then my kids can get it, unsell it off.
There you go.
Okay.
There you go. So it just it helps us to find out what the problem is, and therefore can help to counter the problem before it gets into a clinical stage where you then are presented with emergency medicine
So we're
procedures.
really talking about prevention is the key.
Prevention is always the key.
The person who is prevention-oriented is the person who's going to minimize greatly the onset of disease.
Right.
That means they should live longer,
Yes.
and they should live healthier.
Right.
Right.
In fact, they were looking at a thing called AGES, which is advanced glycation end products. And what they're finding is in some of these longevity diets is to reduce the amount of calories that you have just to keep down the sugar processing in the body, because the advanced glycation end products is what actually adds to the aging of the body, of the tissues, not allowing them to regenerate and things.
All right,
Also.
I interrupted you then. How do you measure this advanced glycination that you were talking about?
Okay, here's one of the ways. Advanced glycation end products, if we bring up the slide, is where you see what's going on here is you see some sugar that's sticking to the outside of the walls of these red blood cells. And that sugar is the glycation that's taking place, and it actually attaches to hemoglobin A1C. And what it does is it looks at the last 90 days. And what we find is that normally medical doctors look at this in regard 7% as good glycemic control. Now, some of them now are lowering that, but at the time when we were looking at this, it was at 7%. And then what we look at is at less than 6.5% equals, or greater than 6.5% is actually diabetes and substantial advanced glycation end product formation. Excuse me. Between 5 and 5.5% is increased advanced glycation formation, but the risk for, but it's a lower, well, it's actually an increased risk for diabetes, but it's at least it's lower than the diabetes one at 6.5. Ideal is to keep that below 4.0 for a minimum of advanced glycation end product creation. What happens is basically sugar not only is sticky, but when you have sugar coating on the outside of things, it makes them more crunchy. And so when we look at red blood cells, the reason why they have this like donut shape to them is so that they can kind of twist and curve and make themselves smaller to go through the capillaries. And the spleen is full of a lot of capillaries with a lot of twists and turns. And so when the blood is getting old, red blood cells are getting old, they're more susceptible to breaking because of the sugar that's on the outside. And that's why as they age, they have more sugar on there and it breaks them down. So that's where we have regeneration of blood each time, and that's why it's looking at the last 90 days.
So if it's sticky and it sticks to my red blood cells, could those red blood cells could clump together and predispose me to stroke?
Yes.
Or lack of blood supply to my brain?
Not only does it do that, but it makes the white blood cells sticky, and they stick to the outside of the arteries and to the outside of the joint tissues.
Could I have fibromyalgia then, or arthritis?
Well, arthritis can occur.
Are you telling me that I've been adjusting some patients for the last almost 50 years, and it's really been a sugar problem?
It can be, because what happens is those white blood cells then transmigrate inside of that joint space, and they start to see proteins that they're not used to, and they start to attack those proteins with enzymes that are non-discerning, and it attacks the joints, especially where there's not cartilage covering or the synovial that's covering. It'll attack the joints and create like inflammatory type arthritis.
Does that mean that people who would go on a low carbohydrate diet might feel healthier, that their joint pains would go away?
Yeah.
Really?
Yeah.
Wasn't there
we also find that with
wasn't there some medical
fibromyalgia.
doctor who had that philosophy? What was his name?
He was a heart doctor, actually.
Yeah, and all of the medical doctors were against him.
And in fact, they just did research.
Oh, I must have Alzheimer's or something, but I can't remember his name.
They did research a year or so ago, and they actually found that they were looking for adverse effects of it, and they found in women it actually lowered their cholesterol levels, just as this doctor had talked about.
Really? Are you saying that you and I know a woman that I know? Mm-hmm. I happen to be married to her, right? Or she's married to me, one or the other.
Yeah.
And she's had some cholesterol problems,
yes.
right?
Yes.
And she kind of likes sugars.
Yes.
Because she's in a high-stress occupation, which is living with me.
Yes.
Right?
Sorry, but yes.
And I never eat sugars, but I know that when she's running around with your wife, that they happen to go out like an alcoholic and have a few, right?
Have a few sugars, yeah.
And then what
yeah.
happens? Her cholesterol goes up, and she complains to me about, what is it she complains to me about?
Oh, sometimes joint pain?
Yeah, her knee.
Yeah.
Her knee.
Yep.
Oh, we must not let her see this television show.
Oops.
Oops. Okay, well, how
Cat's out of the bag.
this diagnostic or how this dangerous journey unfolds, how does it unfold?
Okay, so let's look at how it unfolds. First of all, what you have is a healthy blood sugar right at the very left-hand side of here. And as things go on, it'll tend towards reduced insulin sensitivity. And that then raises you start to have carbohydrate cravings and mood swings when you have reduced insulin sensitivity because it's not clearing.
Need sugar.
Yeah, exactly.
I need
It's
sugar.
It's like when it hits 3 o'clock in the afternoon, these people could beg, borrow, steal to get a candy
Does
bar.
that mean if you took somebody who was predisposed to alcoholism
Oh, yeah.
or maybe had an alcoholic syndrome, that maybe if you took sugars away from them, because it would prevent diabetes then,
It would
right?
help the cravings, too.
Yeah, so they'd go on binges more often then, huh?
Well, if they stay off of it for a while, then that craving starts to go away,
Off
as
of
our
what?
sensitivity.
Off of the alcohol or the sugar?
Well, both.
Both. Because is there alcohol? Is there sugar in alcohol?
Sugar turns to alcohol within your system.
Really?
Yeah, oh, yeah.
Oh, I didn't know that.
Oh, yes, you did. That's why you're doing this.
Does that mean why we see so many people who have alcohol problems and we do blood studies on them and all of a sudden their diabetes goes away and they don't care to drink anymore? I thought it was because I led them to Jesus.
Yeah, well, that's part of it,
Is that part of it,
That's
too?
part of
Okay,
it, too,
all right.
Doctor. So then we go on here and we end up with, if the insensitivity to insulin in the peripherals gets even larger, we end up with a thing called metabolic syndrome and insulin resistance. And here we find that cravings go up, blood sugar goes up, their blood pressure goes up, and their triglycerides go up.
Well, one thing I am so happy and proud of that when we record these television shows that everyone on our crew, nobody eats any refined sugars.
Absolutely.
Nobody has any mood ups and downs. Everybody is alert after 12 hours of taping. We have no sugaraholics in our family, right?
Right.
Right, okay.
Right. So then finally, if this continues up along this trend, we end up with type 2 diabetes, where their blood sugar is elevated, their blood pressure is elevated, their appetite is elevated, their thirst is elevated, their urination is also elevated. So what happens is we have a dangerous journey that doesn't end with just type 2 diabetes. There's increased risk to hypertension and cardiovascular disease that goes along with it. That's why we say that this is not only elimination of diabetes, but other related health problems.
You know, it's interesting. We get into a lot of television studios for interviews and things like that, and I've often noticed that there's like Mountain Dew and other kinds of high sugar and high caffeinated beverages sitting next to those newscasters. So caffeine might have something to do with it?
Caffeine might have a little bit to do
Well,
with it.
I'm glad that if you checked my blood, you wouldn't find any caffeine in it.
No. You don't find much caffeine in water.
No.
So we're looking at the initial response. The initial response is to these things is that we already eat right, take vitamins and minerals, and exercise. Those are some of the initial responses that we can have when we give that to you now.
So that's going to take care of it, right?
Well,
Exercise
not all
more,
of it, as we will
just-
see later on, but these are some initial things that we can do.
Initial things.
Right, and really what it comes down to is what do we need to eat? These are answers that we need to have. I mean, what kind of diet is the right kind of diet for
So
this?
if people will listen to us, they'll know what to eat, right? We got all the answers?
Hopefully we'll cover it within the sessions, but a lot of times one answer is not right for everyone. The testing that comes along, that's what tells us what's right, and that's a difference between what we call an allopathic nutritional program and a metabolic nutritional program. The metabolic looks at the individual, not at just the disease.
So allopathic is like aiming a shotgun at them and saying, boom, this is good for you?
Yep. These are nutrients that were found to be good for these kind of people. Throw it at them without any regard for what other nutritional deficiencies might also be exacerbating the problem.
So does that mean if we get a group of people together and we're going to get them all selling the same kind of products, that's get them enthused and everything and say it's good and have testimonies, is that metabolic?
No.
No, it's not.
No,
Oh,
that's,
okay.
Well, I'm sorry, I might have missed the question.
No, you got it right.
You got the whole group of people together, you just gave them one thing, and say it helps a certain percentage of the population, but there's a whole huge segment of that population that has totally been disregarded.
But that's like every medical student, when he or she is in medical school, they're already told that every drug is going to help some people and is going to kill some people and make them worse.
Well, let's get into that in a moment, okay?
In a moment? Okay.
In a moment.
All right.
Because we're looking at these questions where what do we need to eat? And what vitamins and minerals do we need to eat, which we were just discussing a little bit, the difference that testing has for that. And how much and what kind of exercise is the right kind of exercise to help you.
But there must be something wrong with us. We don't have a particular company or product to endorse.
We don't. We don't. Let's go on. Because this is really interesting here. This is from JAMA, the Journal of American Medical Association.
I'm really interested.
Are you interested in this one?
Anything that's printed in the Journal of American Medical Association.
Well, you'll be interested about this one, because what about medication intervention? And what they found within this is that each therapeutic agent, by this research paper, each therapeutic agent as a monotherapy by itself increased 2 to 3-fold the proportion of patients who attained an hemoglobin A1C below 7%. So actually, it helped. It brought them below that area of glycation. However, that's compared with diet alone. That's why we needed some assistance with this. However, the progressive deterioration of diabetes control was such that after 3 years, approximately 50% of those patients that could attain this goal with monotherapy, only 50% of those people could maintain that. Yeah. And by 9 years, that declined to approximately only 25% of those patients. So the majority of patients will then, in this case, will need multiple therapies to attain those glycemic controls that we're talking about with regular medication.
Because they were treating it with a drug, which is the Western approach, give a drug, right. And they just say, well, so you're going to have some adverse reactions, so they're actually going to get sicker over a longer period of time because of the adverse reaction of those monotherapeutic agents.
Right, right. And the thing is that they're finding that those drugs might help initially, but it's not holding. It's because you're not looking at how the body is developing through that. And that's a lot of times when we end up on a medication, we end on it for life.
Well, it's like
and they
alcohol.
just add on to it.
It's like alcohol. It helps some people initially make some sense out of their senselessness. But in the long run, bad.
Right.
Okay, good.
So then we'll look at another article, Recognizing Insulin Resistance Syndrome. And what we find is, if you can recognize these symptoms, do you have sugar cravings and carbohydrate addictions?
No.
Sleeplessness after a meal or occasional sleeplessness at night?
I always sleep perfect.
How about the pattern of late night eating?
I never get up during the night.
And how about altered body composition? This is that you're a little bit more rotund.
Does that have something to do with my bowel movements?
It could have some of that, but it's really more about what's going on the hips and in the belly, on the side. Yeah. You've been doing good in that regard, sir. I just recognize that right now. So what should we say to these good folks here who have been watching this with session 1?
Don't eat sugars. Don't eat refined carbohydrates. They'll ultimately kill you. They really will. And we're not against the sugar industry. We need them. But again, everything needs to be done in balance. It really needs to be done in balance. And by the way, you can have some fun because, you know, Jesus had a great sense of humor. He really did. It's just that most churches make him like a sad God. So laugh at your health, right? Do some good things.
House Call TV has been brought to you by the Fellowship of the Great Physician. For further information, please call at 651-484-8521 or visit our website at www.housecalltv.org. Until next time, thank you for listening to House Call.